So this next group of drugs are called anti-fibrinolytics or lysine derivatives. And so a little bit kind of different um, context here is that these drugs behave as I said, anti-fibrinolytics, meaning that they actually preserve the integrity of a clot. So here we're looking at the opposite mechanism of action of a lot of the drugs that we've talked about in this lecture so far. And so now we're looking at using these types of drugs to produce clotting in the context of rapid blood loss or active bleed. Okay, and there's only two. So basically, aminocaproic acid, also known as Amicar, inhibits really the conversion of plasminogen to plasmin, which is shown here. And there's lysine binding sites, so sometimes you can see these drugs referred to as lysine derivatives because they structurally look like lysine. And what we're doing is we're inhibiting the fibrinolysis pathway. So where would you use these drugs? Basically in surgery to prevent a major bleed out. You can see them used quite readily in emergency type situations, patients that were shot or stabbed, especially in the context of like a thoracic wound. The other drug is Tranexamic Acid or TXA. The full name is listed there. And here we're looking at the ability of this drug to bind to plasminogen. And then when plasminogen is bound, it's prevented from binding to fibrinogen. And if we've got a nice diagram later that shows this. TXA is actually a little bit more potent than aminocaproic acid when you look at in vitro assays, and overall it's cheap. You can use this drug for multi-organ failure as a result of like hemorrhagic shock. And this drug is actually stocked quite readily on ambulances. It's stocked at first aid centers, military war zones. They would all have TXA available quite readily. And actually, the usefulness of this drug was actually recently reported in a kind of a new trial looking at some of these trauma centers and so forth, and how good this drug is compared to aminocaproic acid. And that was a recent trial, just 8 or 9 years ago now. So that's basically it for the anti-fibrinolytics. Let's look at the thrombolytics or the fibrinolytics, and so this is the opposite of that. And the prototype here is streptokinase, which has been pretty much replaced by Alteplase. And then the other drugs there, Tranectaplase and Alteplase, are kind of like the second and third generations. And so the number here refers to the generation number. So these are thrombolytics, and so these are drugs now that dissolve a clot. So now we're kind of back to square one, the way we were looking at a lot of these anticoagulants. And so similarly to heparin, warfarin, aspirin, these are all drugs that are anti-clot. The previous group of drugs were pro-clot, and so we'll talk about when we will use those. Here's the thrombolytic pathway that basically shows where some of these thrombolytic type medications are used. And so you can see Urokinase, Alteplase, Alteplase, and some of these other ones basically are used in this process where plasminogen gets converted into plasmin. Plasminogen activator inhibitor would inhibit that particular pathway. Here's fibrin being converted into its degradation products, and by doing so, this kind of dissolves the clot. And then there's a whole bunch of other drugs that can inhibit that pathway as well. Okay. So let's talk about streptokinase. And so streptokinase, coming from strep, obtained from the beta hemolytic streptococci. And what it does is it actually binds to the circulating plasminogen, and it forms a nice complex that by way degrades and activates it to plasmin. It's got a really short half-life, less than an hour. This is both antigenic and pyrogenic, so it produces an immune response, antigenic, and produces also a slight fever, pyrogenic. Um, some patients have circulating antibodies because of a previous strep infection, so this enzyme can be rapidly deactivated, which is obviously therapeutically not good. They've used streptokinase for acute MI, DVT, pulmonary embolism, and this drug, aside from its antigenic and pyrogenic activities, may actually produce hypotension, and it may actually, in some patients, produce arrhythmias. So streptokinase has really kind of fallen out of favor. It's been replaced by Alteplase and some of these other ones. Urokinase is kind of the immediate uh, uh, generation that came after. Interestingly, uro, as in urine, it was previously obtained from human urine. Now we grow cultured kidney cells in the lab, and there's no urine collection component to this. This is a direct plasminogen activator, really short half-life, even less than before, less than 15 minutes. This particular, because it's made by human cells, is not antigenic, it's not allergic. It's a much safer alternative, and with the same clinical indication. Alteplase is like the second generation, and it's more refined. It's a lot better. It's got a really short half-life. It's less than 10 minutes. It's used for acute MI, specifically during the vessel occlusion, DVT, pulmonary embolism. Much more potent, much more rapid onset. Doesn't produce an immune response, doesn't produce an allergic response. But traditionally it is costly. But the benefits certainly kind of outweigh the costs that are associated with it, and so this is really kind of becoming more and more kind of frontline therapy. You can see Alteplase used for patients, for pulmonary embolism, DVT, acute MI. This drug and others like it in this category have a real high affinity to fibrin. Um, uh, Fibrin-associated plasminogen, and so whenever there's a growing clot or a growing thrombus, these drugs go in there, and they're called clot busters. And so this is an active, so to speak, an active clot that's quite large. Alteplase will literally go in there very quickly, within about 10 minutes or so, and start to bust open that clot and reperfuse whatever organ or group of vessels that are closed. The third generations are listed here. They're even much more specific. They're genetically modified, longer half-life, but more costly, actually quite costly. And so you'll see them probably become more and more used clinically as Alteplase patents expire, and then some of these other drugs become generic over the next 5 to 10 years. Okay, so again, just to kind of summarize, where would we use fibrinolytics? Ischemic stroke, post-MI, pulmonary embolism, PAD, peripheral arterial occlusions, DVTs, and so forth. And so, these drugs go in there, they find the clot, they bust it open. We used to have a question, it might even be still in the curriculum, but essentially it was a scenario where a patient in one of these cases had one of these conditions listed on this slide, and there was no access to an emergency room. I think it was like at a ski resort or something, and there was like a major snowstorm. But the paramedic actually had Alteplase within the ambulance, and so you can give Alteplase, and you can stop one of these processes from really kind of occurring. And so that was kind of the scenario. But that's kind of the concept here, is that in lieu of PCI or angioplasty or physically going in there and removing the clot, you can give Alteplase to literally bust it open. Okay. So just in summary, so we're looking at the fibrinolytics and the anti-fibrinolytics, and so this is kind of a nice summary slide. So here's the patient that has had a stroke or is having a stroke, an MI, a pulmonary embolism, a DVT, and here's this plasminogen to plasmin pathway. And so the goal here is the clot is producing this disease, and so the goal is to dissolve the clot. which can be accomplished by positively affecting plasminogen using one of these fibrinolytics listed here. The flip side of that would be a patient is actually bleeding, say from a knife wound or a gunshot wound. The goal would be to preserve or produce a clot. In this case, we want to inhibit the plasminogen pathway using one of these two drugs. Okay, so that's the kind of gist of the fibrinolytic pathway. And if you have any questions, of course, please email.